Promises of palliative care. The United States will be facing many challenges in the near future that will require a balance between competing health priorities. 83.7 million Americans will be greater than age 65 in the next 20 years, with 18 million of those individuals achieving the advanced age of 85. The sheer number of individuals requiring care, along with spiraling healthcare costs, will require innovative policies to provide ethical, comprehensive, and realistic care to individuals with chronic life-limiting illnesses far before they enter into the terminal stage. Therefore, a policy that increases funding to increase accessibility, education, and specialty practice certification of the advanced practice nurse in palliative care programs is crucial. Expansion of palliative care programs that utilize a routine screening tool will not only contain costs in the last few years of life, but will also ensure the patient's dignity, self-worth, and their individual rights to end-of-life care transitions are respected. Innovations in healthcare financing will also be explored to maximize the number of patients that can benefit from palliative care services. A policy change would be to require all hospitals that receive Medicare and Medicaid funding to offer a structured palliative care program. To accomplish this lofty goal, support of the proposed bill to expand the Hospice and Palliative Care Training Act would require the Department of Health and Human Services to expand funding to provide support for education, training, and the development of palliative. The policy changes will allow the stakeholders to take part in the coordination of palliative care across numerous settings. The advantages of patients being hospitalized during palliative care treatment allows the interdisciplinary team to have open communication about the countless changes in the patient's condition. This will affect the stakeholders because there will be a decrease in the cost of intermittent readmissions. Reduction in hospitalizations is possible due to the increased monitoring and support both during and after their hospital stay. Palliative care is an adjunct component to the medical team associated with advocacy for quality and reasonable services statewide. This multidisciplinary concept is to provide medical services to individuals with incurable diseases. The policy for palliative care is important because it promotes an organized philosophy directed towards symptom relief. It's an additional layer of support for an already stressful situation, allowing the individual and their family members to focus on one another while spending quality time together. This policy provides important comprehensive direction to alleviate pain and suffering while lending support spiritually, emotionally, and socially to maintain one's desirable quality of life. This policy manages the transitions and episodes of care in a patient's ability to complete their own daily functions and utilize outside resources. A person's decline in health opens the way for specialty services to meet their needs. Many of these patients are hospitalized for symptom relief and provision of comfort measures. This policy expansion will allow the medical team to focus on the patient with a clear understanding of their wishes without diminishing the quality of care. To meet the upcoming workforce challenges to support an expansion of palliative care programs in all hospitals will require increased training for staff and specially certified providers competent on addressing end-of-life care. According to Montoya, the number of providers with hospice and palliative care certification at the end of 2015 was only 7,054, falling far short of the needed providers to care for our growing elderly population. Presently, the Affordable Care Act does not provide adequate funding for end-of-life services such as palliative care and severely diminishes the effectiveness of palliative care programs. Therefore, a critical component to the success of the Hospice and Palliative Care Training Act will also be to lobby for the expansion of the advanced practice nurse role in leading primary palliative care teams and support of equal reimbursement rates for APNs from all payer sources. The APN is well equipped to provide staff, patient, and family education to dispel the many myths that surround palliative care that prevent its growth in the United States. Discussion of death remains a taboo subject in America. Not addressing the natural deterioration caused by chronic diseases and the natural dying process increases the risk of patients dying without freedom from all aspects of pain, body, mind, and spirit. While palliative care may no longer have a curative focus, this type of care does allow for realistic conversations regarding the medical interventions that can increase comfort and maintain the highest levels of health possible with serious illness management. Critical issues to address with patients and families are how to make informed decisions regarding nutrition and hydration, freedom from pain, advanced directives such as a DNR status, and timing for signing on to these expanded support services. It has been well documented that almost 30% of Medicare dollars are spent in the last 2 years of life, with the greatest expenditures in the last few months or weeks. According to Vanden Heuvel or Alano, expansion of palliative care services is one way to decrease the burden of chronic illnesses on the healthcare system while continuing to provide quality care management. The Centers for Medicare and Medicaid Services guidelines currently focus on group bundling for diagnosis-related groups in healthcare financing and offer minimal diagnosis models for palliative care. Many families, however, have been made to believe that palliative care is not covered by insurance companies, which is not factual information. Some insurances, like Medicare and Medicaid, cover palliative care in rehab centers, hospitals, and skilled nursing homes. Applying a cost-benefit analysis in relation to adjusted quality of life years is another method for determination of the cost-effectiveness of palliative care. A stellar example is the California-based Sutter Healthcare System that is utilizing a $13 million federal grant to reform their palliative care program in 24 sites. Their innovative program, Advanced Illness Management, or AIM, works to identify patients that would benefit from coordinated care, thereby reducing hospital visits and enhancing the quality of life for individuals with chronic disease management. For the patient, palliative care teams that are initiated in the acute care setting can even translate into slightly greater than 3 more quality living years when enrolled in a palliative care program. Additionally, from Sutter's program alone, almost $9,000 per patient were saved for the payer, and they are anticipating a $29 million savings to the Medicare system. Imagine the potential savings to the entire American healthcare system if funding expansion was secured from the proposed bill for the Hospice and Palliative Care Training Act for early interventions with palliative care teams. Support of the proposed bill to expand the Hospice and Palliative Care Training Act will allow patients to live a better quality of life without heroics when the end of life comes. Most of these people have their familiars at their bedside at the end of life, making a hard situation bearable because they are together during the person's last days. This is where palliative care allows them to share their love while bringing them together in comfort for the final days. Palliative care has been known to decrease hospital costs because of the number of days hospitalized are reduced. In some cases, therapeutic interventions such as diagnostic testing are no longer utilized unless symptom relief is needed. One's decision to extend life with a degree of discomfort and suffering is part of their value system. This is where quantity of life is weighed in conjunction with the quality of life, making it subjective to a person's own value system. Naturally, the clinical team members providing palliative care have their own values and belief systems, but each member must be educated to honor and respect their patients' and families' decisions, even when they conflict with their own. Finally, this is a way to be symptom-free and live life to the fullest until the end.